again, the planning for comprehensive sexual and reproductive health. So the support to helping people in the field to comply with the MISP objective number 6, which is moving us from MISP to comprehensive. It's exciting to know that we can yet again look at the material and get insight into the different tools that we have, that Tuan is helping us, and then we will have from 3 country colleagues feedback on their experience, their thought and reflections on the process. So you will have a general oversight of the tools, and then 3 country examples. We'll have at the end 15 minutes to address questions and answers, and some closing remarks. I can't see all of you, and since everything is very small on my phone, I can also not see how many people are there, but I know that a huge amount of people have voiced interest and have registered for this webinar. I would like to take the opportunity to give special thanks to IWAG, to the Resilience and Emergency Preparedness Sub-Working Group, to Alison and her team, to people like Tuan, all those who've been involved in making this happen, and to make today's webinar a huge step forward for the community to look into the real experiences of this challenge that we're all facing. Before I'm moving the meeting forwards and hand you over to Tuan, a couple of housekeeping issues. There are translation channels available. If you prefer to listen to this in Spanish, French, or Arabic, please look at the bottom of your screen. There's possibilities where you can change the language. The translator should be online. There's going to be strict timekeeping, and I'm going to be shut off in just a second. And as a final word, I'm very honored that somebody put a doctor on me, but I'm a very proud carrier of the profession of midwife. But I'm, happy to have the title for this meeting. I'll hand you over to Tuan. Thank you very much, everybody, for joining. And I hope this is going to be interesting to you. Tuan, the floor is yours.
And one moment, apologies, Tuan, to jump in quickly. I'm going to go ahead and add the interpretation at this moment. Give me one moment while I add so that we can provide Arabic and French interpretation.
Hello, everybody. Good morning, good afternoon, good evening. While waiting, could we get the slide on, please? And yes, absolutely. As a physician, I've learned almost everything from midwives. So I want to make sure that we celebrate the diversity of professional, ensuring that sexual reproductive health is everywhere for everyone. Great. Alison, can I go forward? Can I start, Alison?
Are you able to see my screen?
Yes. So, super. The interpretation team is on board. Yes. Okay, I guess I need to go on. Okay, can we go back one slide, please? Back one slide. Yes, so I want to share today over a few minutes this co-creation process that we've all been involved with over the past 4 years or 5 years. And it resulted in extensive piloting and feedback loops. And you can see on the map that our toolkit has been piloted and was piloted in different continents and different countries, from Kinshasa, the DRC, to Bangladesh, Yemen, and Niger, Iraq, and Syria. Next, please. So Now we walk you through the process for implementing this participatory planning workshop for comprehensive SRH, as well as the preparations and follow-up required. And the objective of the workshop is, as you can read it on the slide, to improve the quality of MISP service and integrate comprehensive SRH into health system strengthening efforts, and develop as well a shared work plan for how to achieve so. While here, an important note, it is designed to support the transition from MISP after an acute emergency to comprehensive SRH. We found out that this toolkit can be adapted and used in protracted and complex humanitarian settings to expand the range and enhance the quality and reach of available services. You will see that the process is pretty straightforward, systematic, and even familiar, as the guiding frameworks are those of the MISP and the WHO health system building blocks. So the purpose of the toolkit is to help catalyze, move forward, and systematize an efficient, participatory, and inclusive planning process. Although the steps and process is described in the toolkit, how it is adapted, tailored, and timed in each setting will look different. So importance of adaptation here for each of the countries, and you will see it in our example. Now we'll walk you through the process, and keep in mind that you need to contextualize our proposed approach. Next, please. So you will see here that the process consists of 3 different phases with various steps in each phase. And the proposed workshop is around 2 days. Note, however, that these 2 days, which is phase 2, has to be preceded by at least 2 months of work and preparation. And after that, an ongoing follow-up and implementation process. Next, please. So phase 1, the pre-workshop preparation, because it was identified through our multiple pilots that it was a key area for improvement. We'd like to emphasize the steps in importance of preparation, which is the stepping stone very much for successful workshop. And I view the preparation as gathering the essential ingredients for a recipe, such as baking a good cake. And the ingredients here consist of detailing mapping of the SRH program before the crisis, so the data and the status of MISP implementation at the time of the workshop, so another set of information. So you need data on SRH programming before, data on the current status of MISP, and you need the people. You need the right amount of yeast, the people who can really move and transform this information into something substantive in terms of programming. And our experience from all the pilots show that the pre-workshop preparation is very much critical in ensuring that the workshop meets its objective, and that we need a right set of people on board. And this is a very much participatory methodology, and therefore as many as the diverse community of participants is a key ingredient for success. Next, please. This slide just shows an example of available tool to take stock of the SRH program before the crisis. By the way, you will receive a PDF copy of this slide so that you can go back to this. So I just wanted to show this very quickly. Next. And this slide just show you example of available tool that will help you to take stock of the MISP implementation. Some of you know the MISP checklist, for instance, the MISP process evaluation tools, kits, etc. Next, please. So mapping key stakeholders, that really is very important. This is critical to ensure an inclusive planning process. Who gets to participate in this decision process is important to consider as it impacts the work plans, and especially for underserved community. We found out that if you cannot get some of these underserved populations on board during the process itself, it's important to get their voice heard and make sure that during these 8 weeks preparation, you've conducted key informant interviews or focus group discussions to reflect their perspective. Next, please. Now that we have completed the preparation, we move into the actual workshop, face-to-face workshop. It has 5 main steps, which I will illustrate here through different pictures. Step 1 to 4 take place on day 1, and step 5 on day 2. So you can see here on your left side a picture of participants in Yemen introducing the the workshop, and this is very important. Opening the workshop is like, as you know, setting the right temperature for your oven and your cake, and an environment that is safe. Some of the participants would have worked in the field, and they would be meeting other colleagues for the first time in a long time, and they will be debriefing and sharing experience. So making sure that what is said is respectful, confidential, non-judgmental. It's about teamwork and a place where everybody feels safe to share and contribute. So don't overlook that introduction and expectation, that welcoming first step. On the right side, you'll see how participants in Bangladesh now present the mapping that was done at the very beginning during the preparation phase. And these steps allows everybody to come on board and understand the situation in terms of epidemiological reality and the set of opportunities and gaps in the current MISP implementation. Next, please. And here on step 2, you see mapping of needs and opportunities. This is something that participants will reflect upon, discuss, and do it collaboratively based on the health system building block as a framework. So you see how in the DRC, the mapping can look like based on the needs and opportunities and the different health system building block on the very top. On the right side, you see how setting planning priorities for comprehensive SRH can look like. And this is about participants working together and setting these priorities based on predetermined criteria such as low-hanging, high-hanging fruit, feasibility, costs, etc. And now, after you have identified a set of priorities, you need to focus, and we propose that you focus on 3 principal priorities in the following step. The teamwork, and this is where each team will take 1 key priorities and massaging, working on it, on who's doing what, where, when, and how. And by the end of the session, a participant will have produced a detailed practical work plan that will allow the next steps, the reporting back, where the 3 different working groups will share their work plan so that we can find synergies and come up with a common work plan. So next, please. So the collective work plan for comprehensive SRH that participants develop at the end of the workshop are really much multi-purpose, as you can see here. And some of the main 3 themes are improving the quality, strengthening health workforce capacity, increasing community mobilization and engagement, for instance, focusing on certain groups such as adolescents and their SRH needs, etc. You will see it in the PowerPoint of my colleagues. And what we have learned very much from all our pilots is that you really need a very strong pre-workshop preparation time. You need to encourage participants to undertake permanent study, such as taking the MISP distance learning module so that everybody has the same level of understanding, and list people and communities that are marginalized, and make sure that this is owned by a larger group of people within your agency in case you need to move on to a next job, so staff turnover. And I want to stress the importance of follow-up and implementation. You've made your cake, but the cake cannot stay on the shelf and it will be eaten by rats and cockroaches. So you need to share it and move it forward. It needs to be eaten and appreciated by friends and families. So this is the importance of follow-up implementation, and the activities include those that are listed on the slide. And I will to give you now a taste of what this cake tastes like in the different countries, and invite my next presenter to come on board.
Okay, and before we do, apologies, Sayantan, one moment to just assign interpretation. I understand that the channels were not available, so one moment and we'll start again shortly. Okay, there seems to be an issue with the channels, so we'll just move forward in English. Apologies for this. Sayantan, over to you.
Thank you, Alison, and thank you everyone for joining this webinar. And special thanks to the presenter who presented and introduced the topic as such. So I will be presenting particularly on the experience from Bangladesh. And in Bangladesh, when we say that we will be focusing on a specific objective which we have worked on. And this means I am presenting this, but this has been an effort of the team, whole team, particularly the people working with the implementation partners, and also with the help of the donors, how we have able to sustain this work over a period of time. So starting with the context, the humanitarian context in Bangladesh, particularly at Cox's Bazar. So Rohingya people face systematic discrimination and statelessness and targeted violence in Myanmar, particularly in Rakhine State, which resulted into a major influx in 2017, and at present close to 885,000 people are staying, Rohingyas are staying in Cox's Bazar in the makeshift camps. And among this, 52% of the demography is formed by the women and girls. So this is in general context of the humanitarian crisis in Cox's Bazar, and health partners, particularly the SRH partners, have been trying relentlessly to address the issues and to improve the access to the SRH, quality SRH care. And as per our humanitarian response plan, you know that the phase 1 and the phase 2, the implementation of the MISP at the early stages, and which translate into the transition from the MISP to the comprehensive SRH. So we have been following this, particularly in this response. And as a part of this planning session or planning of these strategies, we organized the workshop, as my previous presenter has rightly said, that we have done it in 2019, and we had tried to see what are the gaps in assessing the SRH services and how do we plan for providing these services, how do we plan for providing these services or close these gaps. Next slide, please. So if you see here, you can see the same picture that which we have the workshop in Bangladesh in 2019. And you can see that we have prioritized some of the key activities or some of the key objectives from these workshops. And one of them was definitely establishing a referral mechanism with emergency transportation system and linking it to the community, or to establish a community linkage with that. And other than that, we had several others objective or the area of concern where we needed to work. However, for this presentations, we have tried to be very focused on the referral, emergency referral, and the community linkage. Next slide, please. So as you know, as the whole the system, particularly the chain of events, how it happens in a humanitarian crisis particularly, is that any trigger or destabilization event leads to major influx, migration of people, or major influx. And for this case, we see the Rohingya refugees, particularly the large influx into Bangladesh, and which is followed by loss of essential service. That is where we start coming with the MISP, implementation of the minimum essential service package. Whereas then we see a stage where there is restoration of the essential services, and we also see the relative stability and then return to normalcy and then durable solution. And in this between, we see the implementation of MISP and also transition from the MISP to the comprehensive SRH. However, this is very linearly or the ideal conditions we see this. However, we also sometimes see some triggers or some disruption in this process, and which happened also here with COVID-19 pandemic especially, and also with different flash floods and also other natural calamities. But COVID-19 is something which we would like to highlight in this process, what happened during this implementation process. Next slide, please. So as I mentioned that COVID-19 threatened to disrupt the delivery of the services, particularly the SRH services in the response, and moreover the resources. So that is what is always happen when there is a emergency as such, and this kind of infectious disease, or particularly a pandemic. So the resource get diverted to some other key areas. However, there are also some effect of COVID-19, particularly on the accessibility, on the availability, and the acceptability of the services. What we have seen here in Cox's Bazar was the disruptions of the services. So the disruption of services ranged from a reduced operation hours for the obstetric facilities, that is related to availability, and also lack of transportation or emergency service vehicles, that leads to the lack of accessibility or limited accessibility, and also the apprehension of the community to visit facility, that is acceptability of the services as such, and also fear of infection on the demand side and also the supply side, that also falls under acceptability. But how do we address these things? Definitely this has to be addressed with some innovation which is concurrent with our standard programming. That's why we have this slide where we tried to show that definitely standard programming is needed, but there is also a scope of innovation which needs to be concurrently built in this system to provide 24/7 obstetric referral, emergency and referral services. Next slide, please. So particularly when we started with working on the work plan, and in between we saw a pandemic. So we always tried to follow a standard framework that either we adapt, or if we have something we scale up, or we adopt something which has been practiced somewhere. And if we don't have any three of this, definitely we try to look into what can be done newly in this settings. And that is how we also worked on the work plan to improve the 24/7 obstetric emergencies and the referral services, and how to deliver better 24/7 services, particularly which is more acceptable, more accessible, and also available for the population in need. Next slide, please. So in the process, what we saw is that we got a lot of solutions. Some of the solutions are also listed here, and specifically on strengthening the referral services for improving the access, dedicated 50-bedded isolation center, which has a CMOC capacity to deal the emergency obstetric care, and also like expanding the services, community engagement, and intensified maternal and perinatal mortality surveillance. These were some of the solutions which were in this process, and many more solutions were there. However, we tried, next slide please. However, for this presentation, we will be trying to look into some specific focused area. So as you know, the maternal deaths is one of the key issues which needs to be highlighted, particularly in humanitarian settings, when we see that the 1.9 times of the global average of maternal deaths happen in these settings, and primarily due to the three delays, as we know, the delay 1, delay 2, and delay 3. The delay 1 being the delay in decision to seek care, delay 2 being the delay in reaching the health facility, and definitely delay 3, that is receiving the care, delay in receiving the care. So we thought of coming up with an intervention, next slide please, which is to address these three delays, at least the first and the second delay, and particularly very focused on the second delay. So the intervention was strengthening of the referral services for improving the access to SRH services during COVID-19 pandemic. And as I said, that this was very much designed to address the first delay and the second delay. So as part of this intervention, we had two things, that is the emergency referral and transportation system, which is also known as Matri Seva, which is the literal translation of the maternal care in Rohingya language, and also community-based referral services. So these were two components of the overall strengthening of the referral system as such. Next slide, please. So how does this ERTS work? So this is something I think we had thought of, because we didn't get much evidence, particularly about emergency transportation and referral services in humanitarian settings as such. So we went through the different stages, as I said, that we tried to first do some pilots, then definitely see what are the implementation challenges and what were the implementation facilitators were also there. And then we adopted that, and we tried to scale up over a period of time, definitely. So this is how the ERTS looks. So whenever a client calls, or the family member of the client call, or the CHW network calls, this call goes to a hotline number, and this number, again, the person on the hotline divert this call to the driver, and a specific location is located where the vehicle will pick up this case or the person in need, and then definitely this person is taken to the nearest facility which is available, and one midwife and two volunteers to facilitate this referral. And this whole process as such is a GPS enabled tracking system, is tracking the whole process, and definitely the user data and other things are also captured for quality control and assurance aspect. Next slide, please. So this is some of the pictures, particularly for this transportation emergency transportation system, and this is the branding we have been using, particularly in this response right now. Next. So coming to the next part, that is the community part. So in the community part, as this slide rightly explains, that we have a different layer, like the patient reference. So we have a very strong pregnancy surveillance system. So by that, and the CHWs visit the family, the pregnant woman, and we have patient informations. So the CHW facilitates and communicates with the referral facilitators who are based in the community, and the referral facilitators try to bridge the facility and the community. So he arranges the vehicles. These are for outdoor services. So for family planning, for ANC, for PNC. So for this kind of services, these vehicles are used, and this referral mechanism is used. And by doing so, the person reached the health facility, and then after getting the services, the person is again dropped back to the dropping point. Next slide, please. And this is the example, or this is a picture showing some of the community vehicles which are placed right now in the community. Next. So this is our data particularly to highlight how intervention can definitely change the whole narrative, particularly about the service availability during pandemic. So if you see here, we have tried to show the data from 2019, 20, and 21. And if you see here, very specifically, we have marked the pandemic begins when the restrictions comes in and when the interventions were launched. If you see in 2019, we had a very steady facility-based delivery. So this example is just to see the trend analysis for the facility-based deliveries, which is one of the very important indicator for the utilization of the SRH services. So we see here that particularly after this intervention, and also definitely supported by or supplemented by the other interventions which we had on the ground, the facility births have, the percentage of facility births have increased over a period of time. And not only we were able to sustain the pre-COVID numbers, but also the utilization of the services increased during this period of time. This is something I think was very important for us to also know the impact of this program or the intervention as a whole. Next slide, please. So we also did a research study, particularly on the fidelity and the barriers and facilitators to these services. So we have this report also, and if you wish to look into this report, you can look into it. It's a very interesting report. It's a mixed method study. So you can definitely go into this and visit. Next, please. And at last, I would like to acknowledge the SRH working group, particularly for leading on the planning and the implementation of the work plan. And then definitely to our CHWs, the midwives, and the other healthcare providers, those who are on the front line. And definitely our implementing partners, RTMI, PhD, and IRC, for implementing this intervention on the ground. And definitely, last but not the least, our donors for continuing the project. So thank you so much for your time. Over to you, next participant. Thank you.
Now we will have a presentation from Dr. Ashu Lord Fred.
Hello, good morning, everyone. Good afternoon, good evening, wherever you are. I'm happy to share with you a journey on how planning contributed to resilience for sexual and reproductive health in DRC. That will be the plan that I will try to follow in the next couple of minutes. I will try to be as fast as possible to go through an overview of DRC, give you a summary of the planning workshop, which brought together stakeholders from the field. Actually, Tuan told us how the workshops are organized. The whole idea is to identify priorities through a consensus. And in our case, we carry out field missions to identify gaps to be filled in consensus with students, with teachers and mentors, as well as health authorities. Then we had a component on resource mobilization, which led to the implementation of our project, which we titled Strengthening the Health System Through Integration of MISP into MISP of Reproductive Health in Emergencies into basic midwifery training in 3 provinces out here in DRC. If I'll have time, I will share with you one success, some challenges and lessons learned. Slide, please. Yes, so this is the big and large complex business unit of DRC with its fair share of protracted crises over 20 years, fair share of natural disasters. We had a volcano last year, man-made disasters as well. We are in conflict. We have epidemics. You've hardly heard of Ebola for some time, but here we have Ebola, governance issues, poverty, food insecurity, in a big country, which is about 5 times the size of France. Next slide, please. So actually, our participatory planning workshop took place from the 14th to the 16th of August in 2018, with the primary objective to develop a collaborative work plan on expanding sexual and reproductive health services from minimum initial service package to comprehensive sexual and reproductive health care in the region. Our workshop was led by WHO Global Health Cluster and UNFPA with facilitation and support from IAWG Training Partnership Initiative. And it brought together more than 27 partners from the UN, civil society, as well as from the field. Next slide, please. When it comes to the identification of priorities through consensus, actually during the workshop, the provision of comprehensive sexual and reproductive health services with two components were emphasized. But there was also the issue of updating and building existing provider skills so that human resources are trained in comprehensive sexual and reproductive health, as well as a host of other priorities, strengthening health system information, funding, but considering IAWG technical partnership or TPI's mission and focus on capacity development, this is, we had to reduce the scope of our priorities, narrowing it down to strengthening the capacity of midwives to provide comprehensive sexual and reproductive health services in 3 targeted provinces of the Kasai region. And when we talk of a province here, it is actually the size of smaller countries in West Africa. Next slide, please. Yes, so a field mission was conducted. We had 2 representatives from IAWG TPI who traveled to Kinshasa, and we and accompanied us to be able to go down to those 3 provinces with the purpose of visiting midwifery schools in Kasai, Kasai Central, and Kasai GTPI, because this had been identified as a possible funding source. And during the field mission, informal group discussions and exchanges with midwifery students, teachers, and other midwifery training institute staff, program managers, and experts were conducted. There were no formal research, but UNFPA staff undertook additional assessments before and after the field visit. Slide, please. Yes, so actually during those focus group discussions with students, for example, we noticed that there was a high attrition rate for students during the 3 years training program, with main reason being for students not being able to return to school, being financial reasons. Actually out here to be able to raise $300 per year to pay for a student is quite a lot. And apart from paying the 300 USDs per year, students also pay for pre-service hands-on training, even in public health facilities, which should technically not charge a fee. And when it comes to the idea of pre-service trainings, students noted that mentors, teachers in health facilities were not always supportive, or they were not usually very adequately trained as well. And so there were also issues of lack of equipment, even in health facilities where students used to go for practical sessions. Slide, please. From the side of the teachers, there were concerns about their jobs. Salaries of midwifery trainers in public and private sectors were noted to be insufficient, and because of that, faculty members from those public schools actually rely on student tuition for their income. And there were also lots of issues concerning infrastructure. 2 public midwifery training schools lacked sufficient supplies in their skills labs for students to practice skills. There were issues of classrooms which were lacking ample furniture and equipment. And there was a case where students were found to be taking exams on the bare floor. Slide, please. So this is just a quick overview visit to Kinshasa and then the Kasai provinces. So the pictures on the right are actually demonstrating a bit what how the field visits occurred. Consensus on midwifery schools, you find on the extreme right how the team was meeting with teachers and students separately. You find pictures of students. This was the case of the Kasai Central Province. Slide, please. Then the case of the Kasai Oriental Province, you will see, for example, how infrastructure was looking like. And so those are pictures on the right, which give you an overview of how pictures were looking, of how the infrastructure looked like. Slide, please. Then the team also visited Kasai province, and you will see, for example, how a classroom or how classrooms are looking like on the pictures in the right. Slide, please. So actually, after this field visit, we were able to revise a proposal that was then submitted on March 27, 2019 to IAW-TPI, and that is how, with the information gathered from the field, emphasis was laid on integration of MISP for sexual and reproductive health into a revised national midwifery curriculum, and as well as investment into skills labs, classrooms, as well as providing scholarships to midwifery students so as to curb, amongst others, the high attrition rate. Slide, please. Yes, so here, when it comes to the project implementation and the results, like I mentioned, we ended up revising the midwifery curriculum to better position MISP inside. 2 midwifery training establishments were actually rehabilitated, and they benefited from didactic material. And you see, for example, 60 midwifery students received scholarships to be able to eliminate dropouts. 15 midwifery tutors who didn't have midwifery background, so 5 from each of the provinces, underwent an 18 months training in Kinshasa, in the midwifery training institution in Kinshasa, so as to improve on their teaching skills. More than 120 humanitarian midwives have now been trained in the 3 provinces based on the current MISP curriculum. Slide, please. Yeah, this is actually to just demonstrate the new midwifery curriculum on the extreme right. And to get to that stage, there were meetings of a steering committee, which were held, as well as national workshops, which led to the revision of the midwifery curriculum. Slide, please. Here, for example, I was talking to you about much needed rehabilitation. You will see here in the right, for example, the way the classroom was looking like on the left, and then that is the same classroom, the way it now looks like on the right. And this is in one of the schools in the Kasai province in Chikapa. Slide, please. This is to demonstrate to you capacity strengthening of midwiferys, tutors and mentors, as well as the provision of equipment and demonstration on the use of the mannequins. Slide, please. And of course, on this one, I talked to you about the training of humanitarian midwives. This is actually a curriculum which has been developed following actually the introduction of MISP into the midwifery into the national midwifery curriculum. But now we train what we call humanitarian midwives, and so far, like I mentioned, about 120 of them have been trained, and they can now actually be used in the various provinces where there is a humanitarian crisis. Slide, please. This is actually my last slide, just to demonstrate to you when I was talking about the issue of successes with this program. For example, this program brought much needed services and care to both health facilities and communities in hard to reach areas. And in terms of challenges, it was often difficult for UNFPA and partners to provide frequent and adequate monitoring, supportive supervision to those midwives who were actually posted in very, very hard to reach areas because of poor network, poor road infrastructure. Funding also is usually a challenge because humanitarian funding windows are short-lived. But when it comes actually to lessons learned, we believe and we encourage everyone to be able to include MISP into the national level midwifery curriculum if the situation allows. Slide, please. Slide, please. Actually, this is just to say thank you, and with some pictorial demonstration of what our program looked like at the end of it all. So once again, thank you very much.
Thank you, Dr. Ashulor Fred, and Dr. Afra Tabet, over to you for your presentation on Yemen.
Thank you for you and for the colleagues who are presenting. I'm Dr. Afra. I'm going to present the Yemen experience. I'm going to demonstrate with you the map of Yemen that shows the national overview of Yemen geographical location. So from this map, we can see that Yemen has a unique geographical location. It is situated along in the southern part of the Arabian Peninsula. According to the 2021 projection, Yemen population is more than 31 million. Yemen remains a young country as 44% of the population is under 15 years old. 66% of these population lives are in rural. Life expectancy in Yemen is 61 years, while the crude birth rate is 33.4 over 1,000 and the crude death rate is 10 over 1,000. The Yemen is divided into 22 governorates. We can see it from the map, which is shown in my presentation, and with 333 districts. Next slide, please. From these slides, we can see the overview of the health sector of sexual reproductive health project, which is targeted from this project during 2019, that 3 governorate, Aden, Damar, and Eb governorate were targeted. Although the challenging humanitarian context may also present an opportunity to reaching women, men, and young people. The Yemen, there is 2 participatory reproductive health workshops were conducted, one in Sana'a and one in Aden, between February and March in 2019. And the prioritized for these reproductive health activities was 3 districts. One of them was in Al-Udain district, which is in Eb governorate, and the second is Uthman district in Damar, and then the last one is Sheikh Uthman in Aden governorate. This training of trainer will support the additional capacity of the country on the transitional from minimum initial service package or MISP to a comprehensive reproductive health services during this period. So the objective of this training was that of trainer or TOT was to train the participant on how to prepare, deliver documents and follow up on the reproductive health priorities. The TOT was attended by 5 reproductive health specialists, 2 from WHO, 2 from the health cluster coordinator, 1 from UNFPA and 1 from UNICEF. In addition to the Ministry of Health Deputy Health Cluster coordinators, those are specialized in capacity, their capacity is high to do the training and conducted in both areas, Sana'a and Aden. In the slide that we are seeing, the targeted people that for this project was total people in need is more than 2019, and we see that the reproductive age, women in reproductive age, women are pregnant, and the women that expected that with the complication of the pregnancy. So in this project, that 553 reproductive health kits were distributed, 60 beneficiaries in a bulk with essential supplies that distributed to 13 health facilities. 11 over 13 health facilities were assessed and rehabilitation conducted. 13 over 13 of these facilities were equipped with basic furnitures. 94 participants were oriented and prioritized, trained on the workshop during the workshop conducted in both Aden and Sana'a. Next, please. In this slide, we'll see Yemen health cluster on the project of this Yemen project, the sexual reproductive health project, ensuring that health providers, especially those working at community and primary health care level, are trained on the delivery services according to the WHO guideline. Ensuring the financial is not a barrier to service availability, access, and use of guaranteeing that the minimum infrastructure supplies and commodities are always available in these facilities, and ensuring the reproductive health information is included within the health system information. We see this slide that there are like more than 51 health cadres that have been trained on basic emergency obstetric care, and 13 cadre on family planning and counseling during this project, and 23 medical doctors were trained on post-abortion care, 50 participants from health cluster trained on minimum initial service package, 16 medical doctors, midwives, nurses were trained on infection prevention from the health facility, including community health workers. 91 community health workers trained on reproductive messages, reproductive education, community, and 60 midwives that trained on the indicators to record from EB and DMAR. Sexual reproductive health situation analysis were conducted in 3 governorate, Taz, Abiyan, and Aden. Updating the printing of 8 types of guidelines, reproductive health guidelines, and IEC materials, and distribution of those materials to the community health workers and beneficiaries were done. Next, please. We can see from the reproductive health situation in Yemen that Yemen is a key intervention to increase access to and use of reproductive health services and rights are known, and many organizations working in crisis setting are implementing these with extremely limited resources and multiple challenges that they are facing, as we know that politically and the ongoing conflicts happening. There is an urgent need to strengthen the health cluster partners' capacity to both respond to reproductive health needs during the crisis through fully implementing the clinical services, including minimum initial service package, implementation of MISP, support the transition to ensure that comprehensive reproductive health services are integrated into primary healthcare system. For longer term, partners can address the 6 health system building block, including establish political agreement to provide a full package of services as recommended in the MISP implementation. Next, please. Thank you. Yemen has the highest maternal mortality ratio in the Western East Asia. We can see from the chart that Yemen has 164 according to the trends in maternal mortality between 2000 to 2017 within the UN estimates. And we can see the other Arab countries are lowest, like Emirates. So this Yemen is now hold one of the highest, especially within the National Demographic Health Survey conducted in 2013 shows that more than 400,000 maternal mortality ratio over 100,000 live birth. In 2013, also the contraceptive prevalence, we can see from the indicators, women health indicator shows in the table, that the total fertility rate also of women between urban and rural, these are the indicators. This crude birth rate also shows that the rural is higher than the urban, and the birth space in the urban is higher than the rural, and contraceptive prevalence rates shows, as you see in the table, and the unmet need for family planning. Next, please. Okay, we can see from this chart that the partners supporting to the health, including reproductive health services, so to the health and reproductive health services between the 3 years, targeted years. In 2019, it shows low that time because of the starting of the project, maybe because of the continuous, protracted conflict happening. So people are oriented during 2019 and then starting engaging more partners to contribute to the support of the MISP implementation and reproductive health services, targeting 3,000 health facilities, which supported with incentives, which is in the absence of salaries for the government staff, supporting with equipment, medical equipment, including EMOC equipment, emergency obstetric care equipment, as well as the commodities and life-saving medicine. Then it increased gradually to in 2020, although within the challenges of COVID-19 pandemic, and then in 2021, the period was the first 6 months, and it is increasing because of more partners were involved in this period. Next, please. And this chart that shows reproductive health services utilization. We have the indicators for the 3 years of antenatal care, normal delivery, cesarean section, and postnatal care. If you go and see in this chart that the antenatal care in 2020 is higher. This is maybe shows we can justify this because of the number of trained cadre and community-based midwives were higher during this period, although the COVID-19 pandemic, a lot of effort was done by all partners, reproductive health partners, training of the through Zoom, to training on physically. So it was done, but after the development of these COVID-19 prevention guidelines, train all the RH service providers on how to prevent and to reach women even at the community and facility level. This is what shows maybe this is the justification and the availability of the commodities, medicine that distributed through community and at the facilities. The same thing with the normal delivery, it increased, it shows is community-based and facility-based indicator that shows this higher level in 2020 year. And the same thing with the cesarean section and postnatal, we can see those are low because of this pandemic also period. Next, please. The skilled birth attendants, health facility, and home-based. We can see this chart that shows in 2019, 2020, 2021 are similar, that the ranging between community-based shows in the orange color, and then the blue one is the facility-based. It is although increasing in 2019 and 2020, and then gradually decreased because the last 2021 until the report was until the end of June of the year. Next, please. Use of family planning method among married women of the reproductive age. Source is the Reproductive Health Management Information System, which is based on the health facility registration. We can see this diagram that the 2019, the family planning usage or beneficiaries are more than 1,600,000. And then it increases in 2020. The year of 2020 is a very good year, maybe, although there is a lot of challenges, but we see that the beneficiaries was high to 2 million, higher than 2 million. While it start decreasing, this is a very, challenging for all over for Yemen, especially for all those partners, including UNFPA, to support the family planning. It needs a lot of effort to work all together, supporting at policy level that to advocate on the importance of family planning. The distribution also for family planning was limited because of the gap of funding, and these need a lot of effort. It is challenging actually for all of us and needs a lot of effort to be done at this stage to increase the family planning usage or beneficiaries or receiving these services. Next slide, please. The institutional maternal mortality ratio. It is the number of maternal deaths at health facility over the number of deliveries at the health facility to the same period multiplied by 100,000 live births. So we can see in the 3 years difference that 2019 was 249, and then the increase dramatically in 2021 with 359. We are justifying maybe this is of the maternal death in the community may not be fully captured or possible under the priority at the health facility for fear of blame. So they don't want to report about maternal death because they fear that they are going to be blamed or something like that. That's why we as reproductive health partners that we started to implement the MPDSR system in 2019. Next slide. So the distribution of RH kits within this period, we can see that in 2019, most of the partners were interesting to distribute and procure. Most of us is UNFPA and WHO, that the only partners that we are procuring the reproductive health kits. And this distribution was fully, higher level in this 2019, while during 2020, it is reduced because of the COVID pandemic and the PSP delay in the reaching to the country of some of those kits, as well as the distribution internally was very challenging in that period. So that's why it's reducing, and fund constraint because of the replacing of the fund to the PPE procurement. Of that's example of that. So in 2021 started increasing because of the conflict that it's protracted and increasing in the last year 2021 inside the area, and the displaced people are increasing. So the increasing the procurement of those kits for the implementation of MISP were conducted. This source is taken from the health cluster. Next slide, please. Treatment of obstetric fistula cases. Those are obstetric fistula cases in Yemen. It shows that a very challenging situation that we are facing in 2020 because of the COVID pandemic. Most of the women are not able to travel from their districts to reach the fistula center to receive this surgical treatment, as well as the funding gap in the fund because UNFPA is the only partners that's supporting the obstetric fistula in the country. So it's supporting with the accommodation, transportation, investigation, all types of from A to Z is supported those women. As we see, this is a young woman. She is the 16 years old, was the first woman were treated in 2012. This young girl, her name is Fatma, and she used to get married in age of 14 years old, and she was suffering from fistula for 3 years because of obstructed labor. And that's why after we did the surgery, it was successful surgery, and now she has baby and she's living a normal life. And the surgical team or the fistula team that they've been trained for 3 years, in different countries, sharing experience from Sudan, Ethiopia, Uganda, and different countries. So those are the team we based in south and in the north of the country to continue support the women with fistula, obstetric fistula. Next slide, please. The maternal and perinatal death surveillance and response that we started to implement in 2019, it was a joint effort done by UNFPA, UNICEF, and technically UNFPA and WHO, and technically UNICEF gathering in this meeting. It was in Amman. And then in 2020, we, involving the 2 ministries from the Yemen country to attend this and orient them on how to implement this MPDSR. In 2022, we start working all together, establishing the team for PMDSR and work to update the national MDSR forms, conducting introductory workshop for the government staff or health staff and hospital staff, training of MDSR team to start the pilot. And then in 2020, we started the PMDSR pilot in 2 governorates, one from the south and now one from the north. In the south, we targeted Hadramaut governorate and 3 districts in Hadramaut. In the north, we targeted 2 big referral hospitals, Al-Sab'in and Al-Thawra Hospital. Next, please. So the guideline developments, a lot of guidelines were developed by both ministries in the south and the north. One of them is the CMR protocol, which was taking a long time from 2019 until by 2021 is endorsed, and a lot of staff, health workers were being trained on these guidelines, updating community-based maternal neonatal healthcare emergency guideline, family planning package, guidelines, including the DIMPA, subcutaneous. This was recently included in our guidelines, and it's approved by the government to be procured and enter to the country. Essential neonatal care national guidelines. This is one of the guidelines also, and reproductive health service providers guideline during the COVID pandemic. We can see those service provider and midwives, they are going in the camps and they're providing the counseling and from these photos. Next, please. Capacity strengthening, we can see these capacity strengthening, 110 midwives have been trained on clinical management of rape in 2021. 550 health workers, including 220 midwives, almost 800 of them were trained on provision of reproductive health and family planning services during COVID pandemic. 251 midwives have been trained in family planning and counseling, and the decision maker, it was a very challenging period for us, especially in 2019 when we started the implementation of the MISP. We have to orient because most of the ministry decision makers are new people, so they don't have any idea about MISP. There is high turnover at the ministry level and governorate level. So we included and we did an advocacy MISP orientation meeting for 1 full day, inviting all those parliament and decision makers from the ministry to orient them about the MISP implementation. Why is MISP important in this period and how we can go from MISP to comprehensive. In 70 health or more than 70 health coordinators, as the last data, it was more than 110 of them were trained from health facilities and NGOs, INGOs trained on MISP. 40 reproductive health focal points from the all governorates. They've been trained on fistula identification and referral to the facility, because people, they don't differentiate between fistula and hemorrhoid. In Arabic, it has the same word, fistula and hemorrhoid, so they cannot differentiate what is fistula, what is hemorrhoid. They think it's opposite. So that's why we try to train most of the journalists and and the health workers that to identify and refer those cases to the hospitals. Next, please. Increased coverage of reproductive and family planning services, supporting health facilities by providing medical equipment. So this is most probably in the high institutes for health and science, so UNICEF and UNEP and other NGOs supported service midwifery training under the program of midwifery for each village. This is the word of the Minister of Health. Every time is in his speech, he wants us to support midwives. So 11 health institutes were supported. 344 female students were started as a pre-service training from 2020 and 2020, 2021, and now it's ongoing for 3 years. 7 of those health institutes received modern anatomical models, medical equipment trained, and hospitals, library, and a very modern library, like electronic library, were installed for those students. During the 2021 also, more than 64,000 pieces of equipment were distributed to the emergency obstetric care facilities, BMOC and CMOC. This was supported by UNFPA, UNICEF, and WHO. Next, please. These slides shows that the services were provided through community midwife, and the meeting and the workshop were done. While the humanitarian situation in Yemen in the last 3 years, 4.3 million of people have been displaced. More than 76% of them are women and children. Their coping mechanism is stretched in the limit of they are paying the heaviest price, as it is often the case of humanitarian crisis. In general, there are 20.7 million people in need. From them, 12.1 million people in acute need and 4 million displaced people. A Yemeni woman, would have died given life, while another 20 women will suffer injuries, infection, and complication disability during the childbirth and could have been easily prevented. So imagine that by the end of the day today, let's say today, that 12 women would have died during the childbirth. 1 in 3 women cannot, or would like to use family planning and she cannot get, while 6 out of 10 births take place without skilled birth attendants. So I would like to thank and to acknowledge the support and the coordination of the health cluster, in addition to the RH Reproductive Health Interagency Working Group in Yemen from both ministries, South and North, and those who are bringing people together for the efforts that identifying gaps challenging to support the Yemeni women and children. Thank you.
Back over to you, Katrin.
Thank you very much. And thank you very much for those 3 incredible presentations. I would also like to highlight to everybody that there has been a natural evolution to multitasking. So what we added in terms of time to hear these great presentations, we didn't lose it in Q&A because you worked on the side of it. I hope most of it has been addressed. If not, due to time constraints, I will have to close the meetings, but not without a few observations. First of all, thank you for all your participation. Thank you to the team for preparing this wonderful meeting. I think the interest and the participation showed that this is something that needs to be the first of many encounters, and that this is the start of a dialogue that we should maintain at relevant levels, be that in IWAC, be that at country level, be that in cross-cutting efforts. The systematic approach to opening a dialogue regarding the move from emergency response elements that are put into place to address the minimum of SRH to something that is much more working to a comprehensive approach and thus to supporting a health system. I think what we're talking about is, even though I hate the word, it is actually very much at the center of the whole nexus idea. And I think it is a wonderful way to see it happening and playing out in very different ways in these 3 contexts. And it is inspiring to say that this is a systematic approach to a dialogue that needs to open. It will take more or less time in different contexts. And let me just make a reference to the very sad situation of Ukraine right now, where the same dialogue forces us to look at a reverse direction, not going from minimum to comprehensive, but looking at the comprehensive and having to adjust every day to a lower level because of the huge constraints the country is encountering. But even there, the systematic approach is a safeguard to not overlooking priority and is a help to making us look at things in a factual manner and to have it at a participatory, as a participatory and inclusive approach. Without taking more of your time, I would really like to thank you. It's been very inspiring. And I do hope that we will have more of those sessions and hope that we can share more of the experiences from different contexts. We stay at your disposition. You have different contexts. Don't hesitate to reach out if you want the contact of somebody else or to ask for documents. We'll be happy to provide them. Thank you to everybody and have a good afternoon.